2.6 million American women have survived breast cancer. This presentation is dedicated to them. Yes, this year, in 2014, almost 250,000 women will be newly diagnosed with breast cancer. 40,000 women will die as a result of this disease. To understand the disease and to understand the medical terminology associated with it, a good starting point would be the normal breast anatomy. It consists of a large amount of fibrous and fatty tissue in which are embedded the lobules or the alveoli, which produce the secretions of the breast. These secretions are conveyed to the nipple and the areola by a system of ducts. It's important to demystify medical jargon so women can understand the types of breast problems they in fact do have. Let's make a start. Breast cancers are first described as being localized, that is, in situ, which in Latin means on site, the most common of which is ductal carcinoma in situ. Its origins on the lining or the wall of the duct. Here, abnormal cell changes occur. This is the most common form of localized breast cancer, constituting in excess of 3/4 of the cases. It is regarded as a non-invasive form of the disease, though 1/3 may progress to an invasive form. This transformation is currently the object of considerable research. Another form of in situ cancer is that involving the lobule, also called lobular carcinoma in situ. This, like ductal carcinoma in situ, is non-invasive but is present in slightly more than 10% of all in situ neoplasms. As its name suggests, it's restricted to a single lobule. It's not considered a true cancer or even a precancer, but rather an indicator of increased risk for invasive cancer. Women with this form of breast abnormality are several times more likely to develop cancer in either that breast or the other than in women absent this abnormality. It must be differentiated carefully from ductal carcinoma in situ, as it requires observation but not treatment. Ductal carcinoma in situ requires cancer-directed therapies. When the cancer spreads, it's described as an invasive breast neoplasm. Here the growth extends beyond the lobule or the duct. This is a busy slide. The staging cancers, or rather the staging systems by which physicians describe breast cancer, are anatomical, describing the size of the tumor, its involvement with the lymph nodes or distant organs. More importantly now, we also look for biological markers. They're being used for research and to determine treatment and prognosis. They are estrogen receptors, progesterone receptors, and human epidermal growth factor 2 receptors. What are receptors? Receptors are areas in the cancer cell to which estrogens, progesterones, and other active substances can attach themselves. A blockage of these receptors by various medications decrease the rate of growth. The presence of these receptors, thus, is a prognostically favorable sign. Their absence is prognostically bad. When present, there are directed therapies to block them. Well, what are the signs and symptoms of breast cancer? There are usually none. A painless lump may accidentally be discovered. They may manifest themselves as a lump under the armpit or axilla, breast pain or heaviness, changes in the skin reddening or thickening, breast discharge, often blood-tinged, or nipple changes with dimpling or inversion. If these occur, consult a physician. What are the methods we use to screen for breast cancer? The first involves the patient themselves. It's called breast self-examination, and it's portrayed here in the several images. The woman observes the breasts, feels them, and looks for changes. It's felt at this stage that this form of breast cancer detection is relatively imprecise and is largely being abandoned. More common is the screening clinical breast examination. It is performed by a physician or other healthcare provider. It involves a careful examination of the breasts in the direction portrayed by the arrows above. In the examination, the tips of the fingers are used as they are most likely to pick up abnormalities. A deep palpation or deep pushing in may locate abnormalities that are deeper. Well, the bottom line, screening clinical breast examinations are recommended for women at risk for breast cancer. Presently, these include women older than 40 years of age. It's believed that a well-conducted clinical breast examination can detect at least 50% of asymptomatic cancers and may contribute to a reduction in mortality rate in the women screened. However, we're largely going to focus on mammography. Why? Because mammography is most freely available, most freely used, and most freely misused. Mammography is the primary imaging modality in breast cancer screening. It's been proven to be effective in the early detection of breast cancer, but is a relatively aged technology, having been developed in the 60s. Controversies now surround its universal use. Well, what is mammography? Mammography is really a breast X-ray. It involves an X-ray of a breast, and the image is picked up on film and the breast immobilized by two compression plates, one above and one below. There are traditionally two views needed in an adequate mammogram examination. I will describe them. The reason: they help separate overlapping structures from true abnormalities. Because they provide a superior diagnostic profile, their increased radiation dose and cost are felt to be justifiable. Here is one view. It's called the craniocaudal view. That means looking down. The compression here is from above and below. The other view is the mediolateral oblique view, in which compression is from the sides and imaging from the sides. Breast compression is one of the deterrents to mammography in several subjects. It's necessary to immobilize the breast, improve image detail, and to reduce radiation dose. It's been shown that when patient control compression, that when patients tell the technician how much they can tolerate, we have images with equivalent clarity as those obtained by compression directed by the technician or other medical individual. Mammograms can be different. They're based on operator characteristics and reporting. We have film screen mammograms. The image is captured and archived on film. Its drawbacks include an inability to image dense breasts and breast fat ideally, and may miss tumors. Extra images may often be needed, and film is subject to artifacts, and film can be misfiled. They've largely been replaced by full-field digital mammography. Digital detectors now replace film plates, and X-rays are converted to electronic signals and a digital image by computers. There's greater contrast resolution. That's a resolution of the different types of structures than seen on film. The images can be manipulated with the computer, and this reduces radiation and retakes. They can be stored in optical drives and do not degrade as easily as film, and may be read distantly. Well, which is better? Greater diagnostic yield is seen in the digital studies in women who are premenopausal and perimenopausal because they have dense breasts. No differences are seen between the two systems in other women. Now let's look at the abnormal mammogram. Here we see a dense white object, which is calcification, and is highly likely to be associated with the cancer. Similar calcifications are observed in this and may be associated with ductal carcinomas. Calcifications in the breast can be confusing because they may occur within blood vessels in the breast or in the image on the upper right in degenerating benign tumors or fibroadenomas of the breast where they represent and look like popcorn. It's becoming increasingly important to recognize that all breasts have different densities. Some of them are largely fatty, and the tissue, that's the glandular tissue of the breast, is less than 25%. When there's dense glandular tissue, there may be different appearances, and they're described according to their glandular density as being fatty, scattered, heterogeneous or present right through, and dense, extremely dense when the glandular tissue occupies more than 75% of the breast substance. Why are they important? They impact the accuracy of mammographic interpretation. There's an increased risk of breast cancer, almost a threefold increase in risk with glandular densities in excess of 50%. They're present in a greater volume in premenopausal females and those on hormone replacement. Breast size and firmness is not related to breast density. It is now becoming an essential part of every mammogram, and some states mandate its reporting to the subject of the study. Operator characteristics often determine the value of the mammogram study. Teleradiology can now transmit digital images taken to multiple sites, and batch reading can occur, often two separate interpretations by different radiologists of the same study, which improve accuracy. Immediate reads, where the radiologist is on site and reads the study, lessens patient anxiety, but leads to more callbacks, as previous studies taken cannot be used for comparison at that time. Computer-aided detection, where the computer recognizes suspicious patterns, is now used in a large percent of the studies. With this, there is an increased detection of ductal carcinoma in situ and an increased incidence of cancers detected by mammographic screening. Like anything else, experience is important, and basic competence of the radiologist is thought to mandate a reporting of at least 480 studies a year. But even this is thought to be inadequate, as experts think that the radiologist should report on at least 2,500 studies, and often a breast imaging fellowship helps. What are the mandatory elements in a mammogram report? It should state whether the study is screening or diagnostic. It should describe the breast density and should describe the abnormalities using the breast imaging reporting and data system of the American College of Radiology, or the aroubd system, and the descriptors here should include the location of the abnormality, the quadrant, and the clock position. A summary of the findings should be included, and a aroubd classification. Different aroubd categories may be seen on a patient's X-ray. 0, an incomplete assessment, more study needed. 1, negative study. 2, benign findings. 3, possibly benign but needs earlier follow-up. 4, suspicious abnormalities need biopsy. 5, highly suggestive of malignancy. 6. Biopsy-proven malignancy. Now let's move to the controversies. Mammography was and is a good intention. It's an advance that led to the earlier detection of breast cancer. When the belief existed that early detection led to increased cures and eradication of disease would occur with widespread screening. It encouraged universal screening. Till the first study came out in the early 1990s from the Canadian National Breast Screening Project. Here they found that after 11 to 16 years of follow-up and 5 to 6 screening mammographies, combined with breast physical examination and breast self-examination, there was no improvement rather than a single breast physical examination. There were a host of studies that came out in the intervening period of time. However, the one that was most controversial was in 2009, when the United States Preventive Services Task Force recommended that women under the age of 50 without risk factors not be screened by mammograms, and between the ages of 50 and 74 receive the study on a biennial or every other year basis rather than every year. This was supported by studies in Norway, which followed the introduction of breast cancer in different regions and found no real benefit from screening. Earlier this year, a study in the British Medical Journal showed a 25-year follow-up of breast cancer incidence and mortality, once again in the Canadian studies. It concluded that annual mammography in women aged 40 to 59 did not reduce mortality or death beyond that of physical examination, especially when therapy for breast cancer was freely available. It was rather disturbing in that it stated that 22% of screen-directed invasive breast cancers were overdiagnosed, and they represented one overdiagnosed breast cancer for every 424 women who received mammography in their trial. Once again, in 2012, Dr. Blyer from the Oregon Health Sciences University and Gilbert Welch from Dartmouth concluded after studying 3 decades of screening mammography that there were substantial increases of what we describe as early-stage breast cancer, or DCIS. But screening breast mammography had only minimally reduced the rate at which we could detect and intervene in advanced breast cancers where the breast cancer had involved other organs. This is a busy slide from the Wall Street Journal and will be further dissected. The United States Preventive Services Task Force recommends screening beginning at 50 and continuing every other year. The American College of Radiology suggests starting at 40 and repeating yearly. American College of Obstetrics and Gynecology also has the same recommendation as the American College of Radiology. The American Cancer Society also echoes the same recommendations, while the University of California at San Francisco suggests individualizing based on family history, breast density, and age. So let's look at these factors. Race. White women have the highest incidence. Age incidence rises between the ages of 50 and 70. This details the number of women that would require to be screened to prevent one death from breast cancer for each age group. Between the ages of 39 and 49, it would require a screening of almost 2,000 women. Between 50 and 59, a lesser number of women would have to be screened for the detection of one case of breast cancer, while the pickup is even greater as women age. Thus, the recommendations of the United States Preventive Services Task Force that screening may best be utilized after the age of 50. The error rates are also considerable between the ages of 40 and 49 because of the dense breasts and the difficulty in interpretation. For every 1,000 women screened, one will have a false negative result between the ages of 40 and 49, while a false positive results will occur in almost 10% of them. These numbers decrease slightly in older age groups between 50 and 59 and 60 and 69. Are you confused? Most physicians are, and you can be excused. And now let's help you look at this more pragmatically. We had said that screening, the first benefit of screening is to lower cancer mortality. So it must find cancers earlier. And if found earlier, the treatment destined to cause death, the treatment necessary to treat cancers destined to cause death must confer some advantage over late treatment. This would be an ideal screening test. The upper line, early stage cancer with early detection. The lower line, a decrease in late stage cancer associated with screening. But what happened with mammography? Let's take a look. Between the years 1975 to past 2005, there was a remarkable increase in the number of early stage or ductal carcinoma in situ cancers picked up. This paralleled the use of mammography in these women. The conclusion was that following the introduction of screening mammography in women aged 40 and older, the number of women diagnosed with early stage of breast cancer has roughly doubled. However, the number of women picked up and mortality reductions in late-stage breast cancer remained relatively unchanged. So, while early-stage disease increased, late-stage disease did not. Is there some reason for this? We have a third line where the arrow points to, and this represents the incidence of early stage and late stage breast cancer in women under the age of 40 who had no mammograms over the same period of time. There was little change. The conclusion: there's really little change in the rate of breast cancer in women under age 40, suggesting that there's really not been a dramatic change in the underlying amount of breast cancer. So what we run into is a problem of overdiagnosis. This is defined as the detection of a cancer that would otherwise never appear. What are these cancers? These cancers are mainly at the early stage of ductal carcinoma in situ. They constitute the excess. Frequently, it's believed that if these had been left alone, they would not progress and would require no treatment. There has been a minimal decrease in late-stage breast cancer. Though mammography has been hyped, Otis Brawley, the chief medical officer of the American Cancer Society, was quoted as saying, "I'm admitting American medicine has overpromised when it comes to screening. Advantages are greatly exaggerated." But breast cancer is intensely personal, and in addition to that, it's become highly political, highly commercialized, and very confusing. The old way of thinking about breast cancer is as a progressive disease that gets more deadly over time. This would support the earlier beliefs that early detection is the best way of saving life and improving prognosis. But this has recently been challenged. It's challenged in the fact that a new belief has arisen that assumes the following: that breast cancers are more complicated, all breast cancers are not alike, not all breast cancers can be found, not all breast cancers can be cured, and most important, not all breast cancers need to be treated. And it's the type of tumor that matters more than the size of the tumor. So screening and treatment has both risks and benefits. Let's explore them. The benefits. Most important, a reduction in death. This is seen much more in populations with a higher prevalence of disease and a type of disease that responds to treatment. Research suggests that the greatest benefit occurs in women aged 50 to 74 years and far exceeds that for women aged 40 to 49. To exemplify this, almost 2,000 women between the ages of 39 and 49 would need to be screened for the detection of one breast cancer. As detailed earlier, error rates are much higher in younger women than older women. The confusion continues. Let's explore the harms. The harms include false positive testing. False positive testing means findings that sometimes turn out to be benign and no disease. They increase the earlier a woman starts having mammograms and the more mammograms she has, and are much more common in women between the ages of 40 and 49. There are risks from radiation. Radiation itself causes damage to the cells. It's a risk factor in breast cancer, and cumulative radiation is a concern. Americans today receive 7 times as much radiation from medical tests as they did in the 1980s. There's no safe limits for radiation exposure. And there are uncertain but increased risks of breast cancer with increasingly cumulative radiation exposure from mammography. Dr. Barry Kramer from the National Cancer Institute tried to analogize this controversy about breast cancer, stating that there were 3 types: the turtles, or non-aggressive, non-invasive form of the disease, which would never be life-threatening even if untreated. The bears, which are in hibernation and needed to be found before they woke up, and the birds, very aggressive, and no matter how small when found, could not be effectively treated because their spread was rapid and far. The problem: we can't tell the birds from the bears and from the turtles. What are the harms of overdiagnosis? A woman receiving a diagnosis of invasive or non-invasive breast cancer, which may not be significant during their lifetimes if they had not been screened. Other harm is overtreatment. Overtreatment is present when cancers which were unlikely to be lethal are treated, and often they create a cancer phobia for the rest of that woman's life, and frequently, when found, are not responsive to any treatment, as in the cancers that lack receptors. The Swiss have recommended most recently that mammography screening programs be totally abolished. The reason? A woman's perception of the benefits of mammography far exceed the realities when studied. Perception and reality are not synonymous. Well, let's go to how we can calculate an individual's risk of breast cancer. The website detailed here is a website from the American National Cancer Institute and provides a risk tool by which a woman can calculate her own risk of breast cancer. This breast cancer risk assessment tool from the National Cancer Institute can be self-administered. It involves whether there is a personal history of ductal carcinoma in situ or lobular carcinoma in situ, or even chest radiation for diseases such as Hodgkin's or other blood disorders. It incorporates a history of the breast cancer-related antigen 1 or 2, or the genetic syndromes in families with a familial history of breast cancer. It includes age, and this tool cannot be used for women under the age of 35. The age at the time of the first menstrual period is included. The earlier the first menstrual period, the greater the risk. Age at the time of the live birth of the first child, the later this live birth, the increasing risk. It includes whether the patient has had a breast biopsy and whether it's been positive. It includes ethnicity and subrace. This is what it looks like. It has drop-down response boxes requiring a yes or no response, and then it automatically calculates a female's risk. So let's look at one of these. Here's a 40-year-old female, no symptoms, who demands a mammogram, no family or genetic history of breast cancer, her first menstrual period at age 12, and she was 25 years old at the time of her birth of her first child. Her 5-year risk of developing breast cancer by this stool is 0.6%, and being cancer-free is 99.4%. So let's look at a few more factors that are associated with risk. We have factors that increase the risk. There's a 4-fold increase in risk after the age of 65 when a biopsy has shown there have been abnormal changes in the breast, either the ducts or the lobules, when there is a presence of breast cancer-related antigens, when there are mammographically dense breasts, when there's a personal history of early onset breast cancer that's under the age of 40, and when 2 or more first-degree relatives with breast cancer are diagnosed at an early age. The risk is less but considerable when there's a personal history of breast cancer after the age of 40. There are high circulating levels in the postmenopausal female of estrogen or testosterone, a history of radiation to the chest, and 1 first-degree relative. A slightly increased risk is seen with alcohol consumption being of Ashkenazi or Eastern European Jewish heritage, diethyl stilbestrol or DES exposure, early menstruation, extremely tall women, higher socioeconomic status, late age of first pregnancy greater than 30, late menopause, where the individual has never breastfed a child, in the presence of obesity, and when there's a personal history of endometrial or uterine, ovarian, or colon cancer. The long-term use of menopausal hormones containing estrogen or progesterone, or recent oral contraceptive use. Well, what about genetic predisposition? The human genome is gradually being sequenced, and now we recognize that there are certain genes that are associated with a high rate of cancer. 2 of them have been identified: the breast cancer-related antigen 1 and the breast cancer-related antigen 2. They're present only in 1 to 2% of the population, with a high incidence in Ashkenazi Jews. However, their presence for breast cancer would suggest that there's a high likelihood, between 40 to 70%, of the development of breast cancer by age 70 in individuals with breast cancer-related antigen 1, and a slightly lesser risk in those with breast cancer-related antigen 2. It's believed that almost 10 to 15% of all breast cancers are related to variants of these genes. Commercial tests to detect them are now available. The United States Preventive Services Task Force advises that they only be used in women with a strong family history. The American Cancer Society is even more specific, that they be used only after consultation with a medical geneticist. Even more recently, a new gene mutation, the PALB2, has been recognized. Here, the risk of breast cancer is extremely high. Well, what does an individual do? It's important that the physician direct the patient. Media coverage has not been helpful. A study from the Center for Medical Consumers of reports on ductal carcinoma in situ concluded that women were often described as being confused, but physicians never were. That the media made opportunities to show half-naked women, and the number of letters in support of mammography far outnumbered those opposing it. An article way back in the New York Times in 2002 stated that doctors are a weak link in the diagnosis of breast cancer, that radiologists miss far more tumors than previously assumed, that the government had minimal standards for radiologists interpreting mammography, and even among radiologists, mammographic interpretation had a low status, the problem compounded by decreasing reimbursements and soaring malpractice rates, so radiologists went towards something easier and more lucrative. It's really sense, not common sense. Now, to a real dialogue. What is the likelihood? A population-based likelihood shows that breast cancer will be approximately 14% of all cancers detected, but will cause only 6.8% of all cancer deaths. And even if diagnosed with breast cancer, one had a 90% chance of a 5-year survival. 1 in 8 American women will develop breast cancer. It's believed that the death rate due to breast cancer is declining, most likely due to improved treatments rather than screening. It's accepted that advice must be individualized. The decision to screen any women with an average risk should involve consideration of cost and benefit. Benefit, reduction in the risk of death. Cost, consideration of financial, radiation-related effects, pain, anxiety, false positive diagnosis, overdiagnosis. That's diagnosis of cancers that would never become clinically evident. The risk-to-benefit ratio in the average woman is determined by age. There's a steep increase in the cancers detected after the age of 50, and it peaks almost at 75. Women aged between 40 and 49, not real benefits are seen in cancer detection. Between the ages of 50 and 69, mammography is universally recommended, and all trials show reduction of death in this age group. For women above the age of 70, there is no adequate data for recommendations to be made, and it should be generalized and based on the patient itself. The frequency of screening. Mammograms conducted every other year showed no change in mortality for women between the ages of 50 and 69, but showed a greater detection of late-stage cancer where we could do nothing between the ages of 40 and 49, but even these were infrequent. As stated earlier, digital is superior to film screen. Each professional group has different guidelines, so all decisions must be individualized. So let's conclude mammography, that the guidelines apply only to women at average risk, that the woman must be risk stratified before screening is started. Mammography is definitely associated with earlier detection at all ages, but then is also associated with an increased number of false positives. And there's frequent overdiagnosis that pick up cancers that will never be a problem. This can be reduced by a physician's knowledge of screening benefits and limitations and individualizing the ordering of mammography. Profit centers sponsoring radiology and their personnel are obligated morally to avoid false advertising unneeded callbacks annually for all patients, and putting pennies before patients. All radiologists are not equal in correct mammographic interpretation. The proponents of mammography and the opponents of universal screening mammography have not been helpful. The sound of their medical debates has much noise and much more nonsense. As a recent article stated and summarized the problem, it broke it down to a smoke detector analogy. It stated that smoke alarms save lives, but also stated most rational people buy smoke detectors realizing that cost and time, just like in mammography, is necessary. Most people will never have a fire, as most women will not develop breast cancer, but 12% do. If you never have a fire, the detector or mammography in this analogy is a waste of money. It's possible your detector is faulty as mammograms are, as mammograms do not detect all breast cancer. Or the fire can be so fast spreading that it overwhelms the detector, as in late-stage cancers. And the detector may sound an alarm detecting heat in your fireplace, as mammograms may overdiagnose ductal carcinoma in situ and indolent disease. But most important, and the most necessary part of a smoke detector, is that it could wake you up and save your life. So, we should test smarter. It's felt that the combination of early detection and modern therapy provide a means of reducing breast cancer and mortality. The benefits of screening outweigh the risks, and it's felt and was concluded that the charged language used, the extreme positions taken, detract from coherent communication of complex issues. Well, let's look at the costs. Annualized costs for screening mammography, as shown in this article from the Annals of Internal Medicine, would be approximately $10 billion a year. All women do not get screened, so our actual costs in the year 2010 were close to $8 billion for mammography, recalls, and biopsies. If we used the United States Preventive Services Task Force guidelines, this cost would be reduced to slightly near $3 billion, while it would even fall lower if women were screened every other year. Well, let's look at this in a global picture. The National Cancer Institutes have a budget of under $5 billion. The excess from unneeded mammography could be better directed, don't you agree? As Everett Dirksen, the senator from Illinois, once said, "A billion here, a billion there, pretty soon you're talking real money." We're talking real money. Other screening tests include the following: breast ultrasound. Here there's no radiation, no compression, and when added to mammography, increases cancer detection by a factor of nearly 30%. However, it's not ready for widespread use. It's not very specific. It's got a higher cost and not freely available. It's also got a low sensitivity for calcifications. Here's a breast ultrasound detecting breast cysts. Well, what about breast MRI? Excellent tissue differentiation, high sensitivity for breast cancer, not limited by breast density and no ionizing radiation. It can be used for tissue differentiation, especially in implant evaluation, where mammography and ultrasound is inconclusive, for cancer staging, response to chemotherapy, and search for a primary neoplasm that is not detectable, but is not really beneficial for widespread cancer screening. It's much more sensitive than mammography, detecting 55% more cancers than mammography and ultrasound combined. New therapies that are on the horizon include breast tomosynthesis. The machine is something like this. It's once again a radiation-based procedure, but now images the breast in 3 dimensions, developing images that are millimeter thick of high resolution. It has better sensitivity, fewer recalls, it may reduce radiation dosage, and there may be less compression. Here on the right, we see a better defined breast cancer detected with tomosynthesis over mammography. There will be fewer recalls. There's a potential for lower doses. Unfortunately, one view will not be enough. Compression is not needed to minimize tissue overlap, but will be needed to reduce patient motion. This is a technical slide detailing how it works. Its performance is considerably superior to mammography. My conclusion: screening for breast cancer in the female with average risk must be individualized. Breast self-examination is not recommended as a screening procedure. If a patient notices changes or symptoms, medical evaluation is suggested. Clinical breast recommendation is yet recommended when done appropriately. Mammography is the most available and proven modality. Its use, adoption, and interpretation should also direct attention to avoid its drawbacks. New imaging modalities like tomosynthesis will probably replace it. Regardless of technology, the burning question, which images really need treatment. Molecular imaging combined with tomosynthesis may be an answer. Thank you.